Something's wrong. The slide's not working. Okay. As for the percent fat loss, of course, we couldn't do it on children, so it was only done on basically clients above 19 years old. We see during the first month we had a drop in percent body fat of almost 3.5% for females aged 19 to 30, and by the end of the second month we had a drop of almost 6%. Compared to males same age, let's see, we had 6% the first month and almost 9% at the end of the second month. For the waist-to-hip ratio, first month we had, I'll take the same age group at 19 to 30 years old, almost a 2.5% drop in the waist-to-hip ratio, and by the end of the second month we had almost 3.5 to 3.8% drop, while for the males it's the figures are not very far from each other, but we see a higher drop in the males group than the females on the waist-to-hip ratio. It's 3.5 first month and then almost 5% at the second month. We have, just to mention it, that almost 15% of the clients coming to Diet Center from Saudi Arabia, these are all branches in Saudi Arabia, are diabetic. Unfortunately, we don't always have references on the blood test. They just give the blood test at the first time, and we have to really insist on bringing other blood tests after the follow-up. We had only 37 clients complying to the recommendations that we did ask them, so we were able to include them in the study. At the end of the second month, we see an average weight loss of 5 kilos for diabetic, drop in percent weight basically of 5.2%. The interesting is that the fasting blood sugar average did decrease 58% milligram per deciliter, which would make almost 23%. And we had an average reduction of postprandial blood sugar of 61.5 milligram per deciliter, which would make almost 39%. As for the weight loss, well, we can see we did compare those taking insulin to those just on medication, basically, and we also see a bit more, a higher amount of weight loss with those, of course, not on insulin. But we see the difference in the average fasting blood sugar is not considerable. It's the same drop in blood sugar with a percentage basically of 17% for those on insulin and 22.3% of those on medication. We also took the basically, yes?
In just a few minutes, try to finish.
Sure, we're done. The patients with dyslipidemia, we only had also 9 complying basically patients. Just as a fast drop, we see 7% in weight loss, triglycerides 34.3, and basically LDL a drop of 19.5, which affected the, of course, total cholesterol. Concluded by Madam.
Okay, thank you, Hannah. As a conclusion, children obesity should be treated as soon as being diagnosed. Number 1, should always target behavior of children when giving a diet for the child, whether it is a structured diet or a pre-packed meal program. I would like to thank Dr. Aad Qahtani for giving me this opportunity, and I would like to thank Diet Center Riyadh and Jeddah team for helping me in their data, and special thanks to and appreciation to the Munajjam family, the owner of the franchise of the Diet Center, for the tremendous efforts to keep the Diet Center for the past 15 years of education message and helping the Kingdom Society to better health. Thank you.
Thank you very much. We now move on to the second presentation of the session by our visiting speaker, Professor Maury Ayman from Baylor Medical College. Professor Ayman is the interim chair of the Department of Pediatrics and a professor of pediatrics and the chief of the Pediatric Endocrine Division at Baylor.
Thank you. Do we have a slide? We do. Okay. Well, it's good to be here again, and it's good to see all you this morning. This morning, I would like to tackle several topics that are going to be not directly, but they are interrelated in a sense. I have a pointer here. One is methods for measuring body fat and its relationship to the etiology of insulin resistance in most of the obesity syndromes, and then methodologies for actually quantitating insulin resistance on a clinical basis. This is my choice? But I think those are three different choices. My conflicts have not changed since yesterday. I think we have a large number of methodologies for being able to assess body fat. Some are fairly straightforward and very inexpensive, and some are very expensive and can only be applied in a research setting. So first of all, some of the things we've talked about is just straightforward measurements of height and weight, from which one can, in the younger child, get the height-weight ratio. BMI, which is Suzanne just mentioned. We'll talk about DEXA. We'll talk about visceral subcutaneous fat, hepatic fat, and intermyocellular fat, the latter three of which are all research tools. So certainly the easiest thing is for a primary care physician to be measuring the heights or the lengths and weights of children up to 2.5, and then taking into consideration the weight for length ratio. Although it's crude and is a very early form of what has been evolved into the BMI in older populations, it is extraordinarily useful when following children in the early months of life. As we've seen, the BMI is a methodology for taking the kilograms, dividing it by the meters squared. And this is a growth chart in BMI, plotting a child who's sitting up here at the 95th percentile, and pointing out the fact that this number changes as the graph changes, so one does not have a fixed number to look at. And therefore, it's very important that one have an appropriate BMI chart to be plotting this on, since we do, on a clinical basis, put a tremendous amount of emphasis on this BMI measurement. For epidemiologic studies, large population studies, this is probably the gold standard in terms of cost effectiveness. But it is full of its own problems. BMI predicts increased body fat. At least that's what we hope it does. The problem is that if one has a high BMI, you can be pretty assured that that individual has high body fat. But if they have a normal BMI, then I think the issue is not so clear. It may predict normal body fat that's for adults is less than 30%. In children, this would then be related to issues of insulin resistance, and we do, and I'll show you in a second, we will find within the normal BMI individuals who have high body fat despite the BMI being within the normal limits. And therefore, we see children who have high insulins in the normal range, and so looking at insulin values just by BMI will give you misleading data. You need to know what the body fat content is. And so I will show you some data on that. And then the other issue is the intra-abdominal fat, which is probably thought to be the most important thing in predicting insulin resistance, which is the preamble of all the medical complications that we associate with obesity. So let's talk about the DEX first, because it is the key standard upon which I'll make the comparisons for the BMI. DEX is a dual energy absorptiometry, and it's basically used in women to look at bone densities and look at mineral content, but it also is quite an accurate measure of body composition. Clearly, it has its own internal problems from the standpoint that you're still making an assessment of lean body mass on the basis of the water content. And for those who have not seen it, it's basically a table. You go through a scan, and you get bone mineral density here. You can get body composition scans here. And it will give you a measure of the total percent body fat. It is not so good at giving you a measure of lean body mass because of the water distribution problems. But if you look at BMI, and these are adult women, and these were done at Texas Children's Hospital with Ken Ellis. If you look at just a normal population of women, if you get up here at a BMI that's above 27, you see that clearly the percent body fat is well above 30%. So clearly BMI predicts body fat. But if you go down below what is a normal body BMI index, you see that there's a substantial number of individuals who have increased body fat even though their BMI is in the normal range. So the BMI is a relatively sensitive tool for picking up obesity, but it's an insensitive tool in picking up all people with obesity. So I think we underestimate dramatically, if you can imagine that, the degree of increased body fat that individuals have. This is interesting from the standpoint this pattern holds for children who are Hispanic and African American and Asian children, and not quite so much for the Caucasian patients in our study population. Another assessment of body fat is to look at either a CT slice through the mid-abdominal space or an MRI. Clearly not something you will do for an epidemiological study. But in doing that, one can separate out the subcutaneous fat from the intravisceral fat. And it is this intravisceral fat that does predict insulin resistance much more so than does the subcutaneous fat. Now, if you look at children, and these are studies done by my colleague, Dr. Sunahag, and we picked, these are Hispanic kids, they are adolescents, and they are selected because of their body composition based on DEX. And if you look at that and then do the mid-abdominal slice, here's the subcutaneous fat in those children, and here's the intravisceral fat. And if you look at the obese children, who are defined as children that are above 30% body fat, you will see that the subcutaneous fat is dramatically increased, as in the intravisceral fat. And both of these are significant at the p less than 0.01 level. Now, a recent research tool that is basically being used, I'm showing it just to expose you to the concepts, is to be able to look at intrahepatic and intramuscular muscle fat using MRI as a spectroscopy tool, not as a scanning tool. And within the abdomen, you pick out the liver, and this is a vertical slice, and then you pick out an area within the liver and you measure a number of what are called voxels, which are small areas in which one scans very carefully. And by looking at the T1 weighted signal in that voxel, you can measure the intrahepatic fat. And from that standpoint, you can measure without doing a liver biopsy, but it is clearly much easier to do a liver biopsy and measure the fat than sometimes getting these scans. In a similar fashion, here's the liver fat, and here's the liver fat in an obese child versus a control child. And you can see the dramatic differences here. This child was normal, was healthy, did not have elevated LFTs, but had liver content fat that put them in the degree of hepatosteatosis. Now you can do the same thing with the muscle, but that's a little more tricky because of the intra and extracellular fat that is stored within muscle. And you end up with the signal when you pick out a voxel and do the measurements. You measure basically two peaks that are fat signals in a T1 weighted signal. And this is the intramyocellular fat, this is the extramyocellular fat, and this is the intramitocellular fat. And you cannot really get good separation in these peaks, and therefore you have to do extrapolations of what these curves might look like. And it is far more difficult to do this study than it is to do the intrahepatic fat. But if one was trying to do sequential studies, say post bypass, to look at intravisceral fat and intrahepatic and intramyocellular fat, it would be something you could do on a daily basis without risks to the patient. All right. The one things that I did not mention, and I obviously got the first talk that I put in rather than the revised talk, I didn't talk about measuring fat by electroimpedance, nor about using calipers and looking at skin fold thicknesses. Both of those measures, I think, for most research individuals have fallen by the wayside because of the individual observer coefficients of variation of replicate analysis when you're talking about skin fold thicknesses, and for the lack of confidence in the data from the bioimpedance. It measures far more than just body fat, and fluid shifts, electrolyte shifts, I think day of the year shifts, moon shifts, everything tend to alter that. And it may be okay for your bathroom scales, and it may be okay for sequential measurements in the same individual across time, but for cross-sectional studies, most investigators no longer use it. All right, insulin resistance, the big bugaboo, the big 70-kilogram gorilla that's in the room that we don't talk about because we're just talking about obesity. Insulin resistance is that subnormal response to a given amount of insulin or insulin concentration in the blood, or you can turn it upside down, is that it's a requirement to secrete even more insulin to provide sufficient biological responses, whether that be normal glucose utilization, appropriate suppression of glycogenolysis and stimulation of glycogen synthesis, or other effects on suppressing proteolysis, stimulating protein synthesis, and lipid metabolism, particularly suppressing lipolysis and stimulating lipogenesis. So all of those are a reflection of how much insulin it takes to get a normal biological response because of the feedback mechanisms of the beta cell and the plasma glucose. The primary driver of this is the plasma glucose. So as the glucose rises with insulin resistance, the beta cells are required to put out more insulin to bring the blood sugar down to normal. And that happens and continues going until you exceed the capacity of the beta cell mass to secrete sufficient amounts of insulin to keep the individual euglycemic. That's when you enter into glucose intolerance and prediabetes and then on to diabetes. So we've known about this for decades and decades. It's nothing new. We knew about it as soon as insulin was being used in patients with diabetes, because if a patient was reasonably well controlled, they got an illness of infections, or if they were asthmatic and got treated with steroids, or they had increasing amounts of obesity, then in fact it required more insulin to bring those individuals into reasonable control. We also know that some individuals with diabetes require less insulin. If you are a chronic exerciser, it increases your insulin sensitivity. You've also probably decreased your body fat mass as well. And we know that it was a method of treatment of retinopathy in the 50s and 60s. They would do hypophysectomies on diabetics with progressive retinopathy as a form of therapy. And as soon as you did that, you made the patient basically ACTH and growth hormone deficient. And as a result of that, you found that they were much more sensitive to insulin in those circumstances. We have used for years the insulin tolerance test to measure growth hormone secretion in children. Fat kids require more insulin to get the blood sugars to drop than do thin children. And so, and children with growth hormone deficiency are far more sensitive to insulin than are children who have normal growth hormone secretion. We know that the process is one that involves insulin being bound by the insulin receptor and triggering a series of intracellular events that eventually lead to the movement of the GLUT4 transporter to the cell membrane and increasing glucose transport. And the complexities of this are mind-boggling, as I'll show in the next chart. All of insulin sensitivity that we talk about has to do with GLUT4 transporters, and they are only located in muscle and adipose tissue. So those are the two tissues that are really directing most of the peripheral resistance to insulin that we have to consider. At the liver level, whereas also insulin has effects on glucose homeostasis, although there are not GLUT4 transporters. It's an intracellular mechanism that turns on through a series of phosphorylations, again, liver glycogen synthesis and inhibition of glycogenolysis. Gluconeogenesis, I do not believe, hands up, that's truth, okay, that insulin does anything for gluconeogenesis. We've done studies with measuring hepatic and total body gluconeogenesis using stable isotopic tracers under 3 different methodologies, and postprandial, fasting, whatever. Unless you become acidotic, the rates of gluconeogenesis remain constant. So it's a very unregulated method that we used to blame a lot on, but I think we can't blame it anymore. Now, here is this is not a pattern of behavior change of obesity in Australia, okay? This is the complexities of the cascade of phosphorylations that occur, and I presume not to know much about this, except that we do know that fatty acids and some other factors inhibit the phosphorylation of IRS1 that then inhibits the cascade of events that lead to the post-receptor insulin resistance that we see in obese individuals. Now, how do we assess that in the human individual? The earliest was that of the insulin tolerance test. The gold standard's been the hyperinsulinemic euglycemic clamp. We've used extensively the IVGTT. And then there's the HOMA, the quickie, and then just old-fashioned insulin to glucose ratios, or if the blood sugar is normal, just the insulin or the C-peptide. So let's go through those just very briefly. Phil Cryer in the 80s, 70s, 80s, and 90s really has done a lot of the basic work to understand insulin counter-regulation. But in the early studies, we were giving IV insulin, plummeted the blood sugar down, because there was an increase in the rate of disappearance of glucose and an inhibition in the production of glucose. When the glucose reaches its nadir and starts to move back up, it's still under a situation in which there is significantly more insulin, almost 100-fold more insulin in the circulation, and yet the blood sugar is rising as a result of stimulation of glucose production. And this is because of the secretion of epinephrine and glucagon and growth hormone and cortisol that are the counter-regulatory hormones that we think about. So when we give an insulin dose, we're really looking at the relative sensitivity of this dose of insulin in a single individual with the kinds of counter-regulatory measurements or counter-regulatory mechanisms that that individual can mount. These are some studies from very, very early on, from Brazil, of insulin tolerance tests in normal children and children who have growth hormone insufficiency and kids who have panhypopituitarism, showing that they fall to a greater nadir and their recovery is much slower than that of the normal individual, the normal child. So this is a reflection of increased insulin sensitivity and not decreased sensitivity. And if you had decreased sensitivity under this, you would have a far blunted glucose response. So the IVGTT can measure insulin sensitivity, but it also measures counter-regulation. Since it measures both, it's not very specific. There's lack of clear reproducibility in this test because one day you'll get one response, the next day you'll get another one. And there's potential risks for severe hypoglycemia, and I don't think anybody really uses this methodology, and I would encourage people not to. It requires the presence of a healthcare provider at the bedside. Well, the euglycemic hyperinsulinemic clamp is thought to be the gold standard. It's a very non-physiologic test, and the way this occurs is that you have the subject have IVs in the individual, and your goal is to keep the blood sugar perfectly constant during this entire study. You will usually use some sort of an isotopic tracer to measure glucose production so you can measure hepatic glucose response to insulin infusion. And we use 6,6-dihydroglucose, but for adult studies, you can use tritiated glucose. You then begin a prime dose constant infusion of insulin, which will raise the insulin concentrations to a very constant rate. And it will maintain that concentration throughout the study. Now, if you did nothing else, you'd be sitting there looking at a very prolonged insulin tolerance test and probably would not be in the best interest of the subject. So it's always good if you infuse glucose to keep the blood sugar constant. So the amount of glucose that's infused over this period of time is the indication of how sensitive that individual is to that plasma insulin concentration. Now, if you have an obese subject, their baseline insulins are higher because they're insulin resistant to baseline. You go to the same insulin concentration, and to keep the blood sugars constant, you end up infusing less glucose. So, in fact, this amount of glucose is less than that in the control, and therefore this individual is insulin resistant. The calculation is just looking at the glucose infusion rate, and that is the measure of glucose resistance or insulin resistance. And you can measure hepatic insulin resistance by having this tracer in place and looking at how much this insulin suppressed glucose production in these circumstances. Now, you can clearly see why this would not be a good epidemiological tool, but it is a very good tool for doing some very refined, very specific targeted studies in a very limited number of individuals. But it does require a skill set with a whole clinical research unit behind it and a good laboratory. So, its strengths are it's considered the gold standard. It measures peripheral sensitivity. It can be used with isotope tracers to measure hepatic sensitivity. It gives an easily measurable number to compare, so it's very easy to compare one group to another, but it's almost impossible to get all the data together. The absolute value, however, is dependent upon the rate of insulin infusion that you get in the right ballpark. Some people have done dose responses that makes it even more difficult. The duration of clamp, because no matter how far you carry out the clamp, you will continue to require more and more and more insulin. So you have to define it in your hands as to how long you're going to do the study. And finally, I think there are difficulties in comparing one study from one group to another in quantitative measures, primarily because of the difficulties of insulin assays. Depends on what kit you use, what double sandwich magic assay you have available to you, and for Allah's sake, please don't use a commercial laboratory because the numbers will be all over the map. Its weaknesses, it's expensive, it's difficult to perform. You can only do limited number of studies. The potential risk of hypoglycemic if you're not watching it